Leukemia. And we'll begin as leukemia. Leukemia is a group of malignant disorders affecting blood and blood-forming tissues of the bone marrow, lymph system, and spleen. Leukemia occurs in all ages. It's an accumulation of dysfunctional cells due to the loss of regulation of cell division. It's fatal if untreated. It's thought of as a childhood disease, but the number of adults affected is actually 10 times that of children, and there's an estimated 43,000 new cases diagnosed every year. There is no single cause of leukemia. It is now known, though, that all cancers begin with a mutation in DNA. In addition, there is an increased incidence of leukemia in radiologists, persons who have lived near nuclear bomb test sites or nuclear reactor accidents, for example, Chernobyl, and persons previously treated with radiation therapy or chemotherapy. Although RNA retroviruses cause a number of leukemias in animals, a viral cause for human leukemia has been established only for some patients with adult T-cell leukemia. This form of leukemia is endemic to southwestern Japan and parts of the Caribbean and Central Africa, and is caused by the human T-cell leukemia virus type 1, or HTLV1. This is a graphic of the pathophysiology of leukemia and how there's a proliferation of immature white blood cells in the bone marrow and how the cells infiltrate sites outside of the bone marrow. Classification of leukemia is acute or chronic, and it depends on the cellular maturity and the nature of the disease onset. Acute leukemia is a clonal proliferation of immature hemopoietic cells. Chronic is mature forms of white blood cells, and the onset is more gradual. Again, in acute, the leukemia develops following malignant transformation of a single type of immature hemopoietic cell, followed by cellular replication and expansion of that malignant clone. The classification is also based on the type of white blood cell. There's acute lymphocytic leukemia, acute myelogenous leukemia, acute or chronic myelogenous leukemia, and chronic lymphocytic leukemia. Other defining features of these leukemic subtypes are presented in Table 3125. WC is a 64-year-old man with complaints of general fatigue and recent weight loss. What specific information will you be sure to obtain during your initial nursing assessment? It's suggested that you would talk about the family history of cancer, the personal history of cancer or chemotherapy, a history of unusual or repeated infections, exposure to toxic chemicals or radiation by employment or where he's lived, and if he has a fever, GI problems, or other symptoms. Acute myelogenous leukemia, or AML, constitutes 25% of all leukemias, but 80% of the acute leukemias in adults. It's an abrupt, dramatic onset with serious infection or abnormal bleeding. There is an uncontrolled proliferation of myeloblasts with hyperplasia of the bone marrow and spleen. The clinical manifestations are usually related to replacement of normal hemopoietic cells in the marrow by leukemic myeloblasts, and to a lesser extent, to infiltration of other organs and tissues. Again, see Table 3125. Acute lymphocytic leukemia, or ALL, is the most common type of leukemia in children, and only 20% of the acute leukemia in adults. Immature small lymphocytes proliferate in the bone marrow, usually of B-cell origin. Acute lymphocytic leukemia has signs and symptoms that may appear abruptly or insidiously. If they're abrupt, they usually involve fever and bleeding. Insidiously, they involve progressive weakness, fatigue, pain, bleeding tendencies. There are also central nervous system manifestations. Fever is present in the majority of patients at the time of diagnosis, and CNS manifestations represent a serious problem. Leukemic meningitis, caused by arachnoid infiltration, occurs in many patients with ALL. Chronic myelogenous leukemia, or CML, is constituted by excessive mature neoplastic granulocytes in the bone marrow. They move into peripheral blood in massive numbers and ultimately infiltrate the liver and spleen. Chronic myelogenous leukemia has a genetic marker called the Philadelphia chromosome, which is present in 90 to 95% of CML patients. There is a chronic, stable phase, followed by an acute, aggressive, blastic phase. The Philadelphia chromosome results from translocation of genetic material between chromosomes 9 and 22 and interferes with the normal cell cycle events such as the regulation of cell proliferation. The Philadelphia chromosome is a diagnostic hallmark of CML. Its presence is an important indicator of residual disease or relapse after treatment. However, the presence of the Philadelphia chromosome is not specific to diagnose CML, since it is also found in ALL and occasionally in AML. The chronic phase of CML can last for several years and usually can be well controlled with treatment. Even with treatment, the chronic phase of the disease will eventually progress to the accelerated phase, ending in the blastic phase. Once CML transforms to the acute or blastic phase, it needs to be treated more aggressively, similar to acute leukemia. Chronic lymphocytic leukemia is the most common leukemia in adults. Its lymphocytes infiltrate the bone marrow, spleen, and liver. In chronic lymphocytic leukemia, there is mediastinal node enlargement that leads to pulmonary symptoms. Because CLL is usually a disease of older adults, treatment decisions must be made by considering the progression of the disease and the side effects of treatment. Many individuals in the early stages of CLL require no treatment. Others may be followed closely and may receive treatment only when the disease progresses. Approximately 1/3 will require immediate intervention at the time of diagnosis. The leukemia subtype may be difficult to identify. It may have lymphoid, myeloid, or mixed characteristics, and this has a poor prognosis. There's an overlap with non-Hodgkin's lymphoma. Both involve proliferation of lymphocytes or their precursors. Rare types include hairy cell and biphenotype. Both are abnormal myeloid and lymphoid clone leukemias. Overlap exists between leukemia and non-Hodgkin's lymphoma because both involve proliferation of lymphocytes or their precursors. A leukemia-like picture with peripheral lymphocytosis and bone marrow involvement may be present in about 20% of adults with some types of non-Hodgkin's lymphoma. Although differentiation can be difficult, generally patients with more extensive nodal involvement, especially mediastinal, fewer circulating abnormal cells, and fewer blast forms in the marrow are considered to have lymphoma. A prominent leukemic phase is less common in aggressive lymphomas, except Burkitt's and lymphoblastic lymphomas. The clinical manifestations of leukemia are varied but are usually related to bone marrow failure or formation of leukemic infiltrates. Check out Table 3125 for more information. Inadequate marrow elements cause anemia, thrombocytopenia, and a decrease in the number and function of white blood cells. Additional clinical manifestations include fewer blood cells being produced as the leukemia progresses. The abnormal white cells do continue to accumulate, and leukemic cells may infiltrate organs, leading to splenomegaly or hepatomegaly. Abnormal white cells accumulate because they do not go through the normal life cycle to death. Leukemic cells may cause lymphadenopathy, bone pain, meningeal irritation, oral lesions, or solid masses called chloromas. Solid masses may result from collections of leukemic cells. Leukostasis is a life-threatening complication caused by a high leukemic white cell count in the peripheral blood. Blood thickens and blocks the circulatory pathways. Leukemic white cell counts in the peripheral blood smear are greater than 100,000. The diagnostic studies used to diagnose and classify types of leukemia include peripheral blood evaluation and bone marrow examination. Identifying the type of leukemia is important because the various types have different prognoses and chemotherapeutic regimens. The malignant cells in most patients with leukemia have specific cytogenetic abnormalities that are associated with distinct subsets of the disease. These cytogenetic abnormalities have diagnostic, prognostic, and therapeutic importance. For example, in CML, the finding of the Philadelphia chromosome has good prognostic significance, but not so in ALL. To determine the presence of leukemic cells outside of the bone and blood, lumbar puncture and CT scans are used. Back to our case study, the physician orders a CBC for WC. The white cell count is 110,000, hemoglobin is 10.5, and platelets are 120,000. What problem do his symptoms and lab values suggest? This is the picture of chronic lymphocytic leukemia. The initial goal of collaborative care is to attain remission. Age and cytogenetic analysis often help form the basis of important treatment decisions. In some cases, such as non-symptomatic patients with CLL, watchful waiting with active supportive care may be appropriate. Although a patient may not be cured, attaining remission or disease control is a realistic option for the majority of patients. In some cases, cure is a realistic goal. In complete remission, no evidence of overt disease is found on physical examination, and the bone marrow and peripheral blood appear normal. Partial remission is characterized by lack of symptoms and a normal peripheral blood smear, but evidence of disease is still seen in the bone marrow. Minimal residual disease is defined as tumor cells that cannot be detected by morphologic examination but can be identified by molecular testing. Molecular remission indicates that all molecular studies are negative for residual leukemia. The stages of chemotherapy are induction, post-induction, and maintenance. Because cytotoxic chemotherapy is the mainstay of treatment, you need to understand the principles of cancer chemotherapy, including cellular kinetics, the use of multiple drugs rather than single agents, and the cell cycle. You'll find more information in Chapter 16. Each stage is discussed in detail in the following slides. Induction is aggressive treatment that seeks to eventually restore normal hematopoiesis on bone marrow recovery. The bone marrow is severely depressed by the chemotherapeutic agents. Throughout the induction phase, nursing interventions focus on neutropenia, thrombocytopenia, and anemia, and they provide psychosocial support for the patient and family. Common chemotherapy agents for induction in AML include cytarabine, and cytosar. So let me try that one again. Cytarabine, Cytarabine. So we'll start at the beginning of that bullet. Common chemotherapy agents for induction of AML include cytarabine, which is Ara-C or cytosar, and an anti-tumor antibiotic, anthracycline, such as daunorubicin, which is ceruvidine, idarubicin, idomycin, or mitoxantrone, which is noventrone. After one course of induction therapy, approximately 70% of newly diagnosed patients achieve complete remission. It's generally assumed that leukemic cells persist undetected after induction therapy. This could lead to relapse within a few months if no further therapy were administered. Post-induction or post-remission chemotherapy is either intensification therapy or consolidation therapy. In intensification therapy, there is high-dose therapy given. It may be given after the induction therapy is finished. Drugs that target the cell in a different way than those administered during induction may be added. Consolidation therapy is started after remission is achieved, and the intent is to eliminate remaining leukemic cells that may not be pathologically evident. This may consist of one or two additional courses of the same drugs given during induction, or may involve high-dose therapy called intensive consolidation. Maintenance therapy is lower doses of the same drugs given every 3 to 4 weeks. The goal is to keep the body free of leukemic cells. Each leukemia requires different maintenance therapy. In AML, maintenance therapy is rarely effective and therefore is rarely administered. Combination chemotherapy is the mainstay of treatment. There are 3 purposes: to decrease drug resistance, to decrease toxicity using multiple drugs, and to interrupt cell growth at multiple points. Table 3126 gives examples of treatment regimens used in various types of leukemia. Newer therapeutic drugs are aimed at small molecules that promote the growth and differentiation of leukemic cells. For example, arsenic trioxide, also called Trisinox, which is used to treat acute promyelocytic leukemia, which is a type of AML, causes DNA fragmentation and cell death. In addition, it inhibits cell proliferation and angiogenesis, which is new blood vessel growth. Imatinib, or Gleevec, targets the BCR-ABL protein that is present in nearly all patients with CML and kills only cancer cells, leaving healthy cells alone. The use of specific targeted therapy in the form of monoclonal antibodies is an important treatment modality in hemopoietic malignancies, but cure with these therapies alone is rare. In ALL, prophylactic intrathecal methotrexate and cytarabine is given to decrease the chance of CNS involvement, which is common in this particular type of leukemia. When CNS leukemia does occur, cranial radiation may be given. Biologic and targeted therapy may be indicated for specific leukemias. For hemopoietic stem cell transplant, the goal is to totally eliminate leukemic cells using combinations of chemotherapy with or without total body irradiation. The intention is to eradicate the patient's hemopoietic stem cells. Then they're replaced with those of an HLA-matched donor, or replaced with their own stem cells. The primary complications of patients with allogenic HSCT are graft versus host disease, relapse of leukemia, especially ALL, and infection, especially interstitial pneumonia. GVHD is discussed in Chapter 14. Because HSCT has serious associated risks, the patient must weigh the significant risk of treatment-related death or treatment failure against the hope of cure. In your nursing assessment, the subjective data you'll gather includes a past health history, which includes exposure to toxins, chromosome abnormalities, and frequent infections, what medications the patient has taken, including previous chemo, and surgery or radiation treatments. You can see Table 3127 for more details. For functional health patterns, you might also look at Table 3127. The objective assessment data would be if the patient has fever, lymphadenopathy, or lethargy, pallor. For the cardiovascular system, are they tachycardic or do they have systolic murmurs? GI would include oral lesions or bleeding, herpes and infections, hepatomegaly or splenomegaly. You would look for seizures or disorientation or confusion, and muscle wasting or joint or bone pain. The diagnostic findings would include a white count that may be normal or abnormal, anemia, with the decreased H&H, thrombocytopenia, the Philadelphia chromosome, and a hypercellular bone marrow aspirate or biopsy would be done. The overall goals of nursing planning would be to understand and cooperate with the treatment plan and help the patient get there too, to experience minimal side effects and complications of the disease and treatment, and to help the patient feel hopeful and supported during periods of treatment, relapse, and remission. The patients have many physical and psychological needs. The treatment and prognosis of each patient with leukemia are driven by many factors such as age and the type of leukemia. Patients are not the same. Therefore, it's important that you have an understanding of a patient's type of leukemia, the prognosis, the treatment plan, and the goals. The family also needs help in adjusting to the stress of this abrupt onset of serious illness. For example, there is dependence, withdrawal, changes in role responsibilities, alterations in body image, and the losses imposed by the sick role. Important nursing interventions include maximizing patient physical functioning, providing hope that acute symptoms of treatment are usually temporary, and encouraging patients to discuss their quality of life issues. The diagnosis of leukemia often brings with it the need to make difficult decisions at the time of profound stress for a patient and family. You'll face special challenges when meeting the intense psychosocial needs of a patient with leukemia. Patients may need to be relocated to an appropriate center or be hospitalized. You'll have ample opportunity to tend to needs for supporting and caring. A multidimensional approach is most effective. Unlike treatments for solid tumors, chemotherapy will be administered to patients with leukemia even if they have severe myelosuppression, as it is the underlying disorder that is causing the problem and will not resolve unless it's treated. Patients' survival and comfort during aggressive chemotherapy are significantly affected by the quality of nursing care. From a physical care perspective, you're challenged to make astute assessments and plan care to help the patient manage the severe side effects of chemotherapy. The life-threatening results of bone marrow suppression, which include neutropenia, thrombocytopenia, and anemia, require aggressive nursing interventions. These patients may be at risk for oncologic emergencies such as tumor lysis syndrome, DIC, and leukostasis. Additional complications of chemotherapy may affect the patient's GI tract, nutritional status, skin and mucosa, cardiopulmonary status, liver, kidneys, and neurologic system. You are an important advocate in helping the patient and family understand the complexities of treatment decisions and manage the side effects and toxicities. Knowledge of drugs includes their mechanism of action, purpose, routes of administration, usual doses, potential side effects, safe handling considerations, and toxic effects. WC's wife comes to his next appointment to find out the results of all of his tests. She's quite worried. What's the primary nursing management for WC and his wife? The primary nursing management would be to listen to their concerns and questions and to help them understand what the diagnosis means and do extensive patient teaching about the disorder and the treatment options. For patients requiring long-term or maintenance chemotherapy, the fatigue of long-term chronic disease management can become arduous and discouraging. You'll teach the patient and their significant other diligence in disease management, the importance of follow-up care, and when to seek medical attention. Involving the patient in survivor networks, support groups, or services may help the patient adapt to living after a life-threatening illness. Exploring resources in the community, such as the American Cancer Society or Leukemia Lymphoma Society, may reduce the financial burden and the feelings of dependence. And you must provide the resources for spiritual support. Physical therapy personnel may be asked to develop an exercise plan to prevent post-treatment deficits caused by drug-induced peripheral neuropathy. Most patients should receive the pneumococcal vaccine at diagnosis and every 5 years, and an annual influenza vaccine. Other concerns such as vocational retraining and reproductive concerns for a patient of childbearing age may be indicated. Your expected outcomes would be that the patient can cope effectively with the diagnosis, treatment regimen, and prognosis, will experience no complications related to the disease or its treatment, and will feel comfortable and supported throughout treatment. WC's results indicate he is in the early stages of CLL, chronic lymphocytic leukemia. What would you teach WC about his follow-up care and managing his condition? You would teach him that he needs to keep regular appointments with his healthcare provider, that he needs to get prompt treatment for fever, infections, and any increase in his current symptoms, and that his input is very important in making appropriate treatment decisions. So let's look at this question. A patient with acute myelogenous leukemia is starting chemotherapy. When teaching the patient about the induction stage of chemotherapy, what is an appropriate statement? The drugs are started slowly to minimize side effects. You will be at increased risk for bleeding and infection. High doses will be administered every day for several months. Most patients have more energy and are resistant to infection. The correct answer is B. You will be at increased risk for bleeding and infection. The rationale is that the induction is aggressive treatment that seeks to bring about remission by destruction of leukemic cells. During induction therapy, the bone marrow is severely depressed by the chemotherapy agents, and neutropenia, thrombocytopenia, and anemia may occur. High-dose chemotherapy is administered immediately after the induction phase.